Welcome to the ACP Problem Solving in Oncology webinar series. My name is Dr. Alison Berner and I am a member of the ACP Trainees Committee and an SPR in Medical Oncology at Mount Vernon Cancer Centre. I'll be chairing this evening's session. This evening's webinar will provide an overview of cancer genomics and the genomic medicine service in the UK. The educational content of this evening's meeting is entirely non-promotional, but we are proud to have the webinar series sponsored by Eisai and Roche, world leaders in oncology pharmaceuticals. Our webinars are recorded and will be made available on the EBN Health ACP library within the next couple of weeks. This is free for all ACP members, and you can also access the ACP Problem Solving in Oncology book series within the library. I now have the pleasure to welcome and introduce our first speaker of the evening. Professor Chrissie Thirlwell is the Clinical Director of the Southwest Genomic Medicine Service Alliance, Professor of Cancer Genomics at University of Exeter Medical School and UCL Cancer Institute, and Medical Oncologist at the Royal Devon and Exeter Hospital. She has an international reputation for research into and on the management of neuroendocrine tumours and integrated genomic analyses of this cancer. She is the Secretary of the UK INETS and ENETS Advisory Board and co-chair of the NETRF Board of Scientific Advisors. Her research has focused on integrated genomic and circulating free DNA analyses in neuroendocrine and other solid tumours. Chrissie chairs the Genomics England Neuroendocrine Tumour 100,000 Genomes Clinical Interpretation Group, GCIP, and is the cancer arm representative of the 100,000 Genomes GCIP board. Professor Thirlwell, when you're ready, over to you. Please go ahead and share your slides.
Great. Okay. Well, thank you for the very kind introduction. It's a great pleasure to be here today. I won't tell you any more about myself, as Alison has covered everything over the last minute or two. But what I'm going to do over the next 25 minutes or so is give you a background and an overview of the 100,000 Genomes project, because that really laid the way for the NHS Genomic Medicine Service, which came into being in around 2018 and 2019. I'll then give an overview at quite a high level of some of the current cancer-related activity in the Genomic Medicine Service, and then Deb Sarker will take over and give more detail about how we analyse cancer genomics and how we use that to make clinical decisions in the Genomic Tumour Advisory Board. So I'm going to start with a very brief Genomics 101, just so you can understand some of the concepts and the things that we'll be talking about over the next hour. So the human genome is a wonderful thing. We have 3 billion base pairs of DNA, which measure over a metre in length. They're packed up into a cell nucleus around 6 microns across. And every time a cell divides, this is unwrapped, copied and packed up again. And unsurprisingly, this goes wrong. And that's essentially the basics of how we can define the molecular basis of cancer development. When we talk about whole genome sequencing, which is what the 100,000 Genomes project performed, this is measuring the whole 3 billion base pairs of DNA. When we talk about exome sequencing, it's the 1% of the coding exome. We also talk about some targeted panel sequencing, where certain sequences, or little regions of DNA, are sequenced in isolation to give us information about areas of the genome that we know are important. So we'll be talking about whole genome, exome, and panel sequencing. When we talk about germline variants, this is a variant in the gametes of our parents, which is passed on to the offspring, and it's there in every cell in our body, and we can then pass these variants on to our children. So when we look at germline variants in cancer, it's all around inherited cancers. So examples are BRCA or Lynch syndrome or other inherited cancer syndromes. When we talk about somatic variants, these are absent in the gamete, but variations or mutations can occur at any point during development, including in fetal development, and these aren't passed on to the offspring. And it's the somatic variants which are often which are looked at when we're trying to determine which treatments to base our genomic outputs on. So the 100,000 Genomes project was put into being nearly 10 years ago now, and it was actually a legacy from the Olympics when David Cameron was Prime Minister. And he had quite a personal interest in this piece of work, which is around performing 100,000 whole genome sequences across rare disease and cancer. He had a son, Ivan, with a developmental delay and disability, and it was very relevant to him as a family to undertake research in rare disease. So the 100,000 Genomes Project was launched. Genomics England was then launched in July 2013. This was followed by a national sequencing centre opened by Theresa May in 2016, and then Dame Sally Davis developed Generation Genome, the Life Sciences Report, and this has then just continued to move forward at quite a pace to the launch of the Genomic Medicine Service, and we're the only health service globally to have anything like it. And it was the infrastructure of the NHS that made the 100,000 Genomes Project possible. And there's been a lot of investment and support by the Conservative government for this. And you know, I won't even start getting into politics at this stage, but they've really been very supportive of taking genomic medicine forward. And then most recently in 2019, following the launch of the Genomic Medicine Service, Matt Hancock, before he had to step aside, announced an aspiration to undertake 5 million genome analyses over the next 5 years. So it was an absolute world first in terms of this scale of research, and it was only made possible through the infrastructure that we have in the NHS. So it focused mainly on cancer. So 17,000 cancers were sequenced, and it also focused on rare disease. And these samples were collected across 13 genomic medicine centres. They underwent whole genome sequencing, the whole 3 billion base pairs. And then the results were analysed, and they were looked at from a research perspective in terms of genomic clinical interpretation groups, which I'll come on to again in a few minutes. But information and results were also fed back to clinicians, and they were acted on if that was fed back within an appropriate time frame. But the primary sort of background for this was all around research and education. And when they looked at the initial outputs from the rare disease arms, about 20 to 25% of cases, there's an actionable finding. And this would often have meant an end to a diagnostic odyssey for families with young children with developmental delays. They often will bounce around various different hospital outpatients departments and not have any sort of real idea of what was going on, and it's really sped up the diagnosis for those families. And in the cancer arm, around 50% of cases, there was an actionable mutation that was found, and I'll go on to a bit more detail of that in a minute or two. So since the completion of 100K in 2018, it's also been used very helpfully through the time of COVID, along with UK Biobank. So of all of the participants, there's 17,000 in cancer, 71 in rare disease. There was 35,000 genomes of individuals that had COVID. So that's been very helpful with that type of research. And what's been particularly useful, but also particularly challenging through this, is there's clinical data to annotate the genomic data. And in the cancer arm, this is tumour staging, location, there's SACT information. They also have hospital episode statistics and mental health services statistics and mortality data. Saying that, this data has taken a very, very long time to collect, and it's really held up some of the progress of some of the work in the cancer GSIPs. So this is still, to be honest, a work in progress, but it's really important in order to lead to meaningful outputs of the whole piece of work. Then in terms of consent, there's clinically accredited pipelines for diagnostics and lifetime follow-up of participants with retrospective data access. And those children that were consented through their parents to go into this piece of work are then reconsented when they reach the age of 16. So there's still quite a lot of ongoing work around consent. When we look at the cancer arm, there's 17,000 cancers which underwent whole genome sequencing, which is head and shoulders above anything else that's been achieved globally. When you think of the most common cancers, there's over 3,000 breast cancers, 3,000 colorectal and 2,000 lung, and then varying numbers of the other less common cancers. It's the most incredible and impressive cohort. A sub-analysis of the first 5,700 cancers that went through the programme identified around 50% of patients had a known actionable or potentially actionable mutation. And that's really, really powerful data, which I think has really propelled forward the inclusion of cancer, the somatic cancer analysis in the genomic medicine service moving forward. But I know Deb will come on to, and we all know that actually when real world data with patients in front of us, that figure of 50% doesn't transform into a medicine that we can actually give patients. It drops to near a sort of 10-12%. But it was this data that was very powerful in including cancer in the genomic medicine service moving forward. Some of you may have seen this in the news recently. This is from April, where there was a headline publication from the pan cancer arms. This is from around 12,000 cancers, and it's looking at variations of patterns or imprinting patterns in cancers across a number of different cancer types. So there have been some very impactful outputs from the research element of the cancer GSIPs. This is from pan cancer, but there's also individual outputs from colorectal, lung and breast. Some of these have really been hindered by having the appropriate clinical annotation, but there has been some good steps forward around that in recent months. So it's really the formation, the delivery of the 100,000 Genomes project that led to the Genomic Medicine Service. And the reason why I, as an academic oncologist, became involved in a new NHS service was I truly believe that this is one of the most transformative and forward-thinking services I'll see in the NHS in my working lifetime. And this figure just gives an overview of the trajectory and the pace at which things have been moving forward over the last 10 years or so. So before the 100,000 Genomes project, there might be very specific genomic-related projects in the NHS now, whereas we've moved very quickly over 10 years to having genomic medicine embedded as part of routine care and for every cancer patient. And I think that's absolutely phenomenal. And we want to move towards better predictive markers and ideally towards prevention of disease. We want a more accurate and precise diagnosis. We want to guide and, as oncologists, give the most appropriate personalized intervention and medicines. And our patients are very, very much part of the development of this service, and it's very, very important. So I've just come to my first poll, my question. So if you could answer that, that would be very, very interesting for me to see. Excellent. And I now have a follow-up question, question 2.
We had some technical issues with question 2.
Oh, okay. Should I carry on, Alison?
Yeah, do carry on.
Carry on. Okay, we can maybe answer that later through Deb's talk. So I'm just going to spend the next few minutes describing what the Genomic Medicine Service is and give some overview about the cancer-related activity through that. So the overarching ambition of the Genomic Medicine Service is to provide equitable genomic technology and analysis for all of our patients with national standards and protocols and the National Test Directory, which I just referred to. And in the Genomic Medicine Service that I'm clinical director of in the Southwest, we work very hard around local partnerships, but feeding into national strategy and national delivery. And this was based on the Genomic Medicine Centre model that was put together when through the 100,000 Genomes project. There were 13 genomic medicine centres. That's been rationalised down to 7 genomic laboratory hubs where the samples go and are actually analysed. And these are all integrated with appropriate clinical specialties. And there's a really big element of translational medicine, looking for opportunities for research across academia, industry and pharma. So there's a big, close research-focused relationship. And there's the NHS Genomic Medicine Research Collaborative, which if you're interested, you can find that quite easily through the Genomic Medicine Service website. So genomic sequencing is very much linked to the NHS long-term plan, and there's a new genomic strategy that is being put together over the summer and will be launched again towards the end of this year. But at the moment, the focus of the genomic medicine service is around inherited and rare disease and cancer, following on from the 100,000 Genomes project. But in terms of inherited and rare disease, really focusing on areas of unmet need and rare and sometimes ultra rare diseases, because we know that whole genome sequencing can really yield high diagnostic yields in those scenarios. In cancer and clinical trials, it's around equity of access. And so the region that I work with goes from the Scilly Isles up to Gloucestershire. So it's about giving equity of access for someone in the Scilly Isles as someone who lives in the centre of Bristol. And it's also using that data to drive clinical trials and selection for clinical trials. And it may be that we identify new cancer biomarkers. There's a really ambitious piece of work around performing whole genome sequencing in collaboration with Genomics England in 200,000 newborns, and following those individuals through life. Would be the first country globally to do that. Understandably, there's a lot of ethical consideration and public consultation around this piece of work, so they're starting with a pilot, but I think that's a really ambitious piece of work to be involved with. And also a lot of work around pharmacogenomics. I'm sure you're all aware of DPYD testing for 5FU treatment, but there's other areas in terms of psychiatric and other blood thinning indications in pharmacogenomics. And then one of the areas that was really obvious for me to want to be involved in all this is around the use of new technologies and analytics. So we're involved in Exeter. We run the rapid exome service for sick babies and children nationally, but we're looking to then turn that into a whole genome service. We're also looking at long read technology with Nanopore. So there's a real ambition to include new technologies in this service. So the National Genomic Test Directory is found very easily online. It explains which patients are eligible and what you need to do to access a test, and there's a link to it in that slide. I'm sure the slides we've made available for you. It's updated regularly with some increasing indications coming online for whole genome sequencing in cancer. So the Genomic Medicine Service Alliances, so I'm clinical director of one of 7 Genomic Medicine Service Alliances. I'm the only oncologist, the rest are clinical geneticists. So it's quite an interesting position for me because I have a lot of input in terms of some of the national strategy around this. But there are 7 GMSAs established last year. And we bring together providers. We're not a day-to-day jobbing service ourselves, but we bring together providers and work in partnership to support the clinical teams and the lab that's then running the analysis. And we really focus on equity of access for the genomic testing, access to treatments, increasing access to clinical trials, and also active participation in genomic research. So this is just our patch, and Deb, I know, can give an overview of the patch that he works in, but we cover a population of around 5 million with 6 integrated care systems coming online. We have a large geographical reach from the Scilly Isles up to Gloucestershire. So obviously we have to be quite cunning about how we work with all of these people. And actually COVID in many ways has been helpful for us because we're so used to using formats like this. So we can, with our educational events, we've got a much bigger reach than we may have had previously. This is just very briefly to give you an overview of the types of teams that make up the Genomic Medicine Service. So we have quite a big management team on the right of the slide, but then we have clinical and pharmacy leads and clinical genetic leads, and we all work together around improving education, mainstreaming, and equity of access. And in terms of some of the work that we do, we have pieces of work that are pathway specific, and I'll tell you a bit more about cancer in a minute, but also about inherited risk and rare disease. And then cross-cutting work, again, focuses on equity of access, education, informatics. And informatics can be really challenging within the NHS infrastructure, particularly with the volume of data that's created with whole genome and panel testing. Have a lot of work in communication and engagement, and really active patient and public engagement work as well. And then in terms of some of the work we've done over the last year on the cancer side, there are national projects that all of the GMSAs do, and there's some regional projects that you do in your region, and then you share your experience, and that might be then rolled out nationally. So there's been a national inherited piece of work in cancer around Lynch syndrome and also DPYD and pharmacogenomics. There's massive pieces of work around solid tumour pathology with a focus on lung, so looking at those somatic changes to guide treatment, but also there's some indications for whole genome sequencing, and for that you need fresh tissue to go up to the lab. So there's a lot of work around mapping pathways, engagement, trying to get the most engagement so that you can get the samples and the turnaround times, which is absolutely pivotal for clinicians to make worthwhile clinical decisions. In the Southwest, we've also had some other inherited work around BRCA. I won't say much about rare disease today because obviously this is a cancer-related seminar, but we have been working on sudden cardiac death, and we're the national lead for monogenic diabetes piece of work. And we spend a lot of our time working on mainstreaming, mainly at the moment around clinicians and pathways and supporting them, but for our patients, and also around data. So there are national pieces of work around informatics and how we handle our data, how we embed genomic data into electronic patient records. There's a number of barriers and hurdles, but there's a concerted effort to try and come over that, to get over that. And also a lot of work around technology, and also importing digital images alongside genomic information, for example. So here's just a quick snapshot of the cancer-related work we'll be doing over the next year. There are whole genome sequencing indications in cancer, and there are more coming online, which Deb will talk about. There's a 500 gene panel, which is the workhorse for most solid tumours, but there's a lot of work around pathology pathways to get those samples up to our lab to get them analysed in good time. There's a lot of work around genomic tumour advisory boards, which Deb will talk about. And what we've been doing with some of our clinicians in our region is making a clinical case for change, just to explain why sending the sample and getting the 500 gene panel done as the first step is the best thing to do overall, rather than just having a few genes tested in a local pathology lab. And there's also a National Cancer Genomics Clinical Advisory Group, which has been set up across the NHS with Peter Johnson co-chairing with Dame Sue Hill. And I've been invited onto that as one of the GMSA clinical directors. Cancer Research UK are also part of that group. So that group has just started, and I think it's a really important group to come together, and some of the outputs of that work I'm sure will be made publicly available soon. In terms of our local transformation projects moving forward, we have Lynch, BRCA and inherited leukemia. So we're doing quite a lot of work around inherited cancer in the Southwest, then also the use of circulating tumour DNA, non-small cell lung cancer, more work in pharmacogenomics, and also identifying families where there's a cancer risk and linking up cancer genomics in primary care, because that's really important as well. So with that, with 5 minutes to go, just want to thank you all very much for listening, and I'll take any questions and stop sharing, I guess.
Thank you so much, Chrissie. That was fantastic. Whiz through what is an absolutely huge effort that's been done in the 100,000 Genomes project and subsequent work. We've had a few questions in the chat. The first one came, I think, after your slide describing the genomic lab hubs, and was around sort of how many labs are there that are sort of geared up and ready to go. Obviously there are 7, but are they at different phases within their ability to deliver on various things in the test directory, or everyone can offer everything?
So, and Deb will come on to this, but in England there are 7 GLHs, and I know Deb's talk gives information about devolved nations as well. But if the test is in the National Genomic Test Directory, then every patient should have access to it. And that's what we're working towards. I don't know, Deb, if you wanted to add to that, just seen you pop up.
Yeah, so I think it's fair to say that not every GLH is able to offer every single test on the National Genomic Test Directory right now. So it's a process around which, you know, the genomic laboratory hubs are trying to engage with all of the clinical and pathology teams in the different areas to be able to get that process kind of, if it's not already ongoing, then at least for it to be expedited as quickly as possible. So I think you'll find that there probably is some variation. Obviously, you know, the central thing in all of this, exactly as Chrissie has said, is about equity of access. So if we can't do that just yet, that's absolutely, you know, what we're working towards. So, but inevitably, I'm afraid there will be, just because of the complexity of some of the testing that's already being done, and obviously trying to get as much, you know, obviously trying to centralize it into 7 genomic laboratory hubs has meant quite a significant change in terms of volume, capacity, and obviously the kind of post-COVID recovery is still ongoing for many laboratories.
I've just got something else to add around that, but if an individual GLH doesn't offer that test, it goes to a GLH that does, so the test is still available. And for example, some tests are so specific, our region offers nationally the rapid exome service for sick babies. So there is some, you know, you couldn't and wouldn't expect every single GLH to offer every single test, but so that they do try to work together to cover those gaps. But as Deb alluded to, there are some situations where some GLHs might get up and running with one test before another one, but they do try as best as they can to work together so that that test is still available.
And sort of related to that, a question from Joni: what's the average turnaround time from a biopsy to a result?
So we've been doing a lot of work around that, and we've been using non-small cell lung cancer, because clearly that's a cancer where you need to make clinical decisions and get started quite quickly. And there's a lot of variation, and the work that we've been doing in our region, and Deb can obviously chip in, is obvious the delay in the turnaround time is actually getting it through pathology and up to the lab, rather than the turnaround time in the lab. So we've been pulling apart some pathways where we saw some sort of shocking indications where it looked like it was a good few weeks plus before a result was coming back. And we looked at our pathway in the southwest where, for example, it might have gone from DGH-A into a teaching hospital B, then on to Bristol, and sort of going via just different routes, because they're still following what they used to do before going direct to the place where the test is done. And so there's a lot of work around improving that nationally, and none of us will say, oh, it's perfect, because, you know, we need to have, you know, there are you know, lung advisory turnaround times, and for every tumor type you need a good turnaround time to actually make you know, a clinically useful decision that's helpful for you and your patient. I don't know, Deb, if you wanted to add to that.
Yeah, absolutely. So I think a couple of things to say. So first of all, there are national guidelines around turnaround time. So every GLH, you know, has to obviously try and meet those national guidelines. But it is difficult, and then obviously in certain cancer types, so we've talked about non-small cell lung cancer, that's particularly challenging. So in fact, you know, we at Southeast GLH actually had changed our panel primarily in response to the fact that we weren't able to meet those turnaround times. So we had initially had planned to use a large 500 gene panel called the TSO 500, which many of the GLHs use, but in fact for lung patients we're actually in the process of moving to a different platform called Genomics, primarily because of the issues around more rapid turnaround time and our ability to meet those targets.
That's really, really good to know, because I'm sure all of us have sat on NDTs where things have taken a long time to come back. I'll pose one final question for our second talk, and then I'll save the others for the end. So is it only FFP that's being collected, or fresh frozen as well? And if FFP, is this affecting the whole genome sequencing quality?
So for the panel testing, it's FFP. And things have evolved that you can get really good, reliable data out of that. And for whole genome sequencing, it's still fresh frozen for a tumour, and then you need a matched germline blood sample to go with that. And actually the circulating tumour DNA, the ctDNA work in non-small cell lung cancer is where you may not be able to get a biopsy safely, or you may not have enough tissue, and then you can look for circulating tumour DNA as an alternative.
Brilliant, that's really clear. Thank you very much. So I will now move on and introduce our second speaker of the evening. So Dr. Deb Sarker is a consultant medical oncologist at Guy's, St Thomas's and King's College Hospitals and a reader in experimental oncology in the School of Cancer and Pharmaceutical Sciences at King's College London. He specialises in the management of pancreatic, liver and neuroendocrine cancers, with a particular focus in the development of therapeutics and genomics. He's co-lead for cancer at the NHC South East Genomic Medicine Service and Genomic Laboratory Hub, and assists in development of therapeutics and genomics. He is co-lead for, he chairs the Genomics Tumour Advisory Board. His main research interests are first-in-human and combinatorial development of novel molecularly targeted agents, molecular and cellular immunotherapies, and he is co-lead of the King's Health Partners Experimental Cancer Medicine Centre. He is also the chair of UKINET's Research Committee and an active member of the NCRI Neuroendocrine Clinical Studies Subgroup. He's a training programme director and oncology lead for the MRCP Examining Board. Dr. Sarker, when you're ready, over to you. Please go ahead and share your slides.
Okay, so yeah, thanks again, Alison, for that very kind introduction and kind invitation to speak at this meeting. Alison asked me to basically speak about NHS Genomic Medicine Service and Genomic Tumour Advisory Boards. And I was thinking about how to kind of structure this talk. And in fact, you know, a lot of the discussion that we've just had, even in this 5-10 minutes, you know, we can see there's a lot of hope and promise, but there's also lots of potential challenges. So I've kind of put these 4 questions here, and hopefully as part of my talk, I'll be able to answer some of these. So what are the practical challenges for translating tumour sequencing into clinical decision-making? How do we best embed genomics in our diagnostic and treatment pathways? How do we use genomic data to support use of targeted drug therapy for patients to try and improve their outcomes? And also, how do we use genomic data to increase the number of patients getting access to targeted therapies beyond approved drugs? So as Chrissie has alluded to, you know, the NHS Genomic Medicine Service is part of a kind of wider NHS vision to revolutionise care and obviously move from a one-size-fits-all approach towards personalised medicine. So the focus of my talk is going to be primarily around how we use genomics to improve access to targeted therapies, but really important to also emphasise that personalised medicine obviously goes beyond targeted therapy to considering rapid disease diagnosis and detection and prevention, and you know, things like the NHS Galleri trial using methylation signatures on circulating DNA is perhaps one example of that potential approach. And as you'll be aware, you know, we're in an era where, you know, we're able to really understand the genomic heterogeneity of cancer. And, you know, this is the pie chart of genomic changes in non-small cell lung cancer. And you can see that many of these gene mutations or fusions have specific drugs that we can now use. And this is, you know, changing rapidly. So as we've discussed, you know, really there are 2 important things here. First, how do we ensure patients with cancer get equitable access to high quality genomic testing? So as Chrissie has said, you know, if there's a patient with non-small cell lung cancer in Gloucester or in South London or in Newcastle, that they have the access to the same high quality testing. But it's not just about that. It's also trying to make sure that that patients also have equitable access to matched precision medicine. So that's pretty much what I'm going to try and focus on in terms of this talk. So Chrissie has gone through some of this, but it's just helpful, I think, to reiterate some of the main points. So NHS Genomic Medicine Service was created in October 2018 as a result of the 100,000 Genomes project. And you know, the real aim is to try and embed genomics in NHS care and provide that consistency and high quality equitable care. So it has 6 key elements: the genomic laboratory hubs, and as we said, you know, there are 7 genomic laboratory hubs in England, the use of a standardized national genomic test directory, whole genome sequencing provision in partnership with Genomics England, an integrated clinical genetics service, the GMS alliances that Chrissie has discussed to really support that embedding of genomic medicine, and a national implementation, coordination and oversight function, which is called the Genomics unit. Again, in the devolved nations, there are similar genomic medicine centres. So there's the Northern Ireland Genomic Medicine Centre, the All Wales Cancer Genomic Centre, and there's a similar model in Scotland. So the devolved nations are very much part of this initiative. So what are the actual challenges for translating tumour sequencing into clinical decision making? So first of all, and again, we started to discuss this, is what tissue should we use? Should we use fresh frozen tissue, FFPE? What about circulating DNA? The next question is really around what is the right test? Should we be looking at targeted panels, whole genome, whole exome, even doing transcriptome? So thinking about questions around DNA versus RNA versus combination of the two. At what point in the pathway should we be doing the testing? Should we be doing it at a point where the diagnosis of a primary resectable cancer versus metastatic disease? And if we're doing it in more advanced disease, should we be doing it at right up front or at the point where patients have exhausted standard of care therapies? Can we actually get the testing and reporting done in a clinically appropriate time frame? So this turnaround time issue that we've already been discussing. How do we actually interpret that very complex genomic data at the point of care? So this is where decision support tools and AI become important, and I'll talk through some of that as well later on. Do we actually find actionable targets? I mean, this whole thing of what is actually actionable, and that in itself is a complex question. So, for example, on 100,000 genomes projects, TP53 was defined as being potentially actionable, and I think probably most of us would know that that isn't normally what is regarded as being a actionable genomic target. And do we get our patients to a targeted drug? And when we give the patient that drug, does the targeted therapy have a clinically meaningful impact? So these are all the kind of considerations that we have to kind of think about, and are really multifaceted and increasingly complex. If we actually look at some historic data from the middle and end part of the last decade, in terms of these are large series of studies where they've done large scale next generation sequencing to try and identify patients who had either actionable mutations, and if they received a matched drug. And you can see here that from all of these series, including very big series such as the MSK impact series, that there is quite a significant drop-off rate between the percentage of patients that we actually identify actionable mutations and those that receive a matched targeted therapy. So there is this kind of high attrition rate that we saw certainly in that initial series of large NGS type projects and trying to match patients to these drugs. So we need to create a standardized approach to genomic testing. And so we've come from a situation where we've been doing single gene tests or small NGS panels. So, small NGS panel normally be regarded as, 50 or less. We've been doing it predominantly as reflex testing. There's been kind of competition with pathology for available of tissue, and there's been limited kind of reporting. So currently, as we've been discussing, we've moved towards large NGS panels, which are done across multiple cancer types, and there's a national approach to implementing these panels, and also this kind of future proofing for investigational genes that Chrissie alluded to, that we want to make sure that we obviously cover all of the kind of standard of care therapies and their matched genes, but also thinking about what's coming down the line. And that's quite a big piece of work that Cancer Research UK is currently involved in. we hopefully are delivering high quality testing in an efficient and timely manner. And again, you know, we are now starting to implement whole genome sequencing in selected tumor types, but this has quite a lot of implication in terms of fresh frozen pathways. So what about the future? So I think we're going to see increasing rollout of whole genome sequencing across solid cancers. There's probably going to be a coordination of approach in terms of multi-omics, so considering things like proteomics, and then parallel ctDNA testing for things like minimal residual disease and determining resistance mechanisms for targeted therapies, I think certainly is going to come down the line. And we want to move to a position where we have a much more integrated molecular pathology report that is digitized. Chrissie has mentioned some of the initiatives around pharmacogenomics, and I think, again, that's going to become increasingly important. So this really just gives us a kind of broad overview in terms of where we've been, where we're at, and where we're going to. So how do we embed genomics in our diagnostic and treatment pathways? So this is all really about education, education, education. So we need to enhance the genomic literacy of healthcare professionals, and so there are, you know, multiple initiatives to try and support this. That's one of the primary goals of the GMSAs, and all of the GMSAs have educational training committees. HEE is actually very proactive in this regard and has a genomics education program. I've just highlighted an app that has been developed locally at Guy's by my cancer genetics colleagues called the Q Genome app, which is which I've given you the links here to, and I encourage you to download, and is a really user-friendly way of seeing what's on the test directory, indications for germline testing and somatic testing. And so please have a look at that. And, you know, we've talked about the complexity of things like fresh frozen pathways for whole genome sequencing, and really, you know, the absolutely integral way that pathology has to be involved in this. And so this is very much part of the GMSA initiatives, that we try and do these kind of transformation models. So this is just an example of Health Education England's what they call G-Notes, which is genomic notes for clinicians. So again, I please, you know, encourage you to go onto this website and have a look at these. They're really quite helpful. So, you know, for example, you know, how to complete a test order form. And then there's a number of oncology specific kind of summaries here that, you know, give a little bit of a kind of case presentation, and then what is then you do in terms of subsequent genomic testing. So these are the kind of initiatives that, you know, we're trying to encourage now. And again, just be very grateful for you to go onto these and give us feedback about how you find these, and you know, how we can improve things going forward from here. Because of the complexity of the test directory, we have put in place locally these kind of pathway maps for each of these, for each of the main cancers that are on the test directory. And this, I've just given the example here of colorectal carcinoma, and it basically shows what is done at the local pathology lab, and then what is then sent to the genomic GLH hub lab, in terms of, you know, consideration around germline testing. So for example, Lynch, and what you do related to if you have a abnormal IHC on MMR testing, but then obviously your kind of standard of care testing related to anti-EGFR test therapy and BRAF testing, and also pharmacogenomics here. So we have developed these particular pathway maps that when we then roll out you know, the genomic testing, that this helps clinicians and teams to understand what tests are done at what point in the pathway, and what potentially is done in the local pathology lab, and also what is done in the GLH. So how do we use genomic data to support use of targeted drug therapy for patients to improve outcomes? So I've shown here two kind of press clippings from the time around which the NTRK inhibitor larotrectinib was approved by the EMEA. And it's really the NTRK inhibitors and the NTRK fusion testing which has been kind of the poster child really for how we try and improve genomic testing to give these really incredibly effective class of therapy. And you know, for those of you who don't know, NTRK gene fusions occur across a range of adult and pediatric cancers. The problem that we have is that they're very common in certain rare cancers, such as secretory breast cancer, these pediatric cancers such as infantile fibrosarcoma and congenital nephroma, but found at very low incidence in most of our common cancers, so lung, colorectal, pancreas, melanoma, etc. So that creates a challenge in terms of how we do the gene testing. But there are two NTRK inhibitors which are now available and have nice funding. One is larotrectinib and the other one is entrectinib. And you know, the entrectinib data really is very significant and profound. You know, the response rate is 61% with a median duration of response of 20 months, median progression-free survival of 13 months. And this is a kind of waterfall plot, which, you know, for those of us who, you know, do drug development and so on, we can only dream of seeing. You know, it's really incredible data in terms of the depth of the responses that you see and across all of these different tumor types, many of which, you know, clearly have, you know, very poor prognosis. So these are transformational medicines, and, you know, these have a real ability to really have a profound impact for our patients in terms of you know, the effectiveness of these treatments. But we need to be able to have a system around which NTRK testing is available, and, you know, this type of testing should be done routinely for all patients with advanced cancers. So how do we use genomic data to increase the number of patients getting access to targeted therapies beyond approved drugs? So this is where clinical trials become important, but it's also important to say that, you know, we should also think about compassionate use requests direct to pharma. On the right-hand side, I've given a study design for a basket study called Tapestry, which is a Roche-sponsored a trial where you can see it's multiple arms using drugs from the Roche pipeline, which are matched to specific genomic aberrations. And this trial is just starting in the UK, and it's also going to be followed by a matched CR UK study called Determine. So for any patient with any tumor type, be it adult or pediatric, if you have any of these genomic abnormalities, you have potential access to a matched drug therapy. And this is probably increasingly going to be what we're able to do in terms of you know, these types of basket study, which span across adult and pediatric, and also across multiple tumor types. I think obviously, you know, many of you will be familiar with the umbrella type trials like National Lung Matrix and Precision Panc, but this type of trial hopefully gives access to patients with, you know, less common cancers that often are very limited in terms of trial availability. So, you know, and this is an adaptive trial design. So many of you, you know, who do clinical trials will know that, you know, sometimes you do these trials for 2-3 years, the trial closes. Roche plans to keep this trial open for 15 years. And as one arm closes, they will add other drugs coming through from their portfolio. So very exciting, and hopefully we'll be able to get access to many patients for these types of study. So moving on to the Genomic Tumour Advisory Board. So what is the role of a Genomic Tumour Advisory Board, or GTAB for short? So fundamentally, it's to review and approve the clinical interpretation and laboratory validation of results received from genomic testing. Our aim really is to try and facilitate that dissemination and access to knowledge regarding match therapies for genomic aberrations, and that includes both standard of care therapies, consideration of clinical trials, and as I said, kind of compassionate or off-label drug use. The GTAB very much has to link to tumour-specific MDTs, and so that very much should be part of the role of a GTAB, and the outcome report should be ideally discuss the tumour-specific MDTs and alert of them regarding potential clinical trials targeting specific gene variants. And then finally, you know, a really important part of what we do is around identification of potential pathogenic germline variants and ensuring kind of timely referral of those types of patients to clinical genetic services. So this is our Southeast GLH GTAB, and you know, we have a number of core members. So we have a GTAB coordinator, we have two types of clinical scientists. So we have a somatic clinical scientist and a germline clinical scientist. We have oncologists and hematologists with expertise in genomics, histopathologists with genomic expertise, and clinical geneticists. And actually, there are a number of different GTABs, and different GLHs will actually have different models for GTABs. I'm just describing ours. So we have a kind of central pan-solid tumour GTAB, but there's a completely separate hematology oncology GTAB. There is a neurology GTAB, which is actually very much embedded within the main neuro-oncology MDT. Within Southeast GLH, we don't do pediatric or sarcoma, but those GLHs that have significant pediatric and sarcoma work, you know, will have their own separate GTABs for these indications. So there are different models, and you know, I know in certain GLHs there are perhaps let's say you know, tumor-specific GTABs which have been created. So each GLH has its own you know, model around which, you know, they create this type of structure. So first poll from me is, have you attended a GTAB meeting? Okay, all right, that's helpful to know. And then second question, how confident are you in reviewing a genomic report? Are you extremely confident, somewhat confident, or not at all? Okay, so none of you feel extremely confident. Just over 2/3 of you somewhat confident, and just under a third not at all confident. Okay, that's really helpful for us to know. And it comes back to that education piece that I mentioned earlier. Here's an example of a next generation sequencing report. This is actually a Foundation Medicine report. So Foundation Medicine is actually owned by, was a standalone entity, but is now owned by Roche, and it's probably the largest NGS testing that's done, you know, worldwide, and certainly has very big traction in the US. So there's two types of foundation testing. There's the tumor testing, and this is actually what's called Foundation 1 Liquid CDX. So this is their circulating DNA next generation sequencing platform. Many of the ECMCs had access and have ongoing access to Foundation Medicine through specific programs. So many centers had access to, through what was called a familiarization program, to get the access to these types of report for patients being considered for clinical trials. So you'll see here on the left-hand panel, so this is actually a relatively young patient, 30-year-old with colorectal cancer. And you can see in the box on the left-hand side that what are described as genomic signatures are first described. So these are what is the tumor mutational burden, and what is the microsatellite status of the patients. Obviously, these are you know, markers for consideration of immunotherapy, and then it describes the specific gene alterations. So you can see, you know, there are 4 genes that have come up on this list, and it describes the specific variants for each of those genes. And then it gives, the report is quite extensive, but it then goes through actually much later on the actual specific therapy and clinical trial implications related to each of these specific abnormalities. So you can see here that this patient has a HER2 variant, and also a variant in a gene called RNF43. The VAF, or variant allele frequency, is higher in the HER2 than the RNF43. And then it goes through here some of the potential therapies with clinical relevance in the patient's tumor type or in other tumor types. Obviously, because this is HER2, it's come up with a list of HER2 targeted therapies. So this patient we reviewed in our GTAB. So this is the clinical information here. This is the actual report. We describe the tumor type, the subtype, what was the actual sample, what was the panel, give a kind of clinical summary here. And we review the findings. So this is where our somatic scientists will review these and really think about, are these variants as described? Do we think that these are these kind of driver mutations, or are these merely kind of passenger mutations? And then we describe those additional findings, such as tumor mutational burden and the MSI status. And then we have a review, and we just also see if we think there's anything potentially of significance in terms of the germline, although clearly this is a somatic only test. There's no paired germline with this. So in fact, there was in this particular case, there was a specific gene called KLH-L6, which came up, but this was not actually clinically relevant. But the comment was made in our outcome in terms of, because the patient was so young, to make sure that they've been referred to clinical genetics. And then obviously we reviewed the variants. We found that both of these we felt were driver mutations, and both of these are potentially actionable, so the HER2 and the RNF43 variants, and we've suggested to consider clinical trials targeting both of those variants. And we've actually mentioned here the specific studies that are available, one that was available that I'm running at Guy's, and the other one at Cambridge. Okay, and then we have an outcome here that says variants of potential clinical significance identified, consider for clinical trials of compassionate use access targeting this gene biomarker if clinically appropriate. And we then make a comment in terms of if there's anything potentially significant in the germline. So you might say, well, how can you work out if there are potential trials for patients? So this is where clinical decision support tools and AI becomes really important. So within the ECMC network, we have what's called the EC Trial Finder. And this was really created because of a lack of visibility of open oncology trials, and in particular in our kind of genomic area, that that was becoming increasingly apparent that clinicaltrials.gov and those other things that we often use really aren't fit for purpose and don't really have up-to-date and accurate information. So as part of the ECMC network, this was created really to create up-to-date and accurate trial information. And it also has, that specific molecular information that we really need to be able to match patients as accurately as possible. So this is the link to this. Now, this is actually not, unfortunately, this is not something that everybody can access. It's just actually for clinicians within the ECMC network. But in essence, we use this in our molecular tumor board. And so there's a filter for, the type of cancer. So you can see here, we filtered for colorectal cancer. And we can filter according to the specific genomic abnormalities. And so we filtered for RNF43. And in fact, there were two trials that came up here. And it's this trial that this patient is actually now on at the moment, which I'm doing at Guy's. So it just gives you a kind of idea for how we can link that genomic data to clinical trials. And clinical decision support tools are really important to understand whether if you identify specific genes and variants, what the clinical significance of these is. And so this is OncoKB, which is a clinical decision support tool actually created by Memorial Sloan Kettering. And you can see here, it kind of gives you a bit of a brief description of the the gene. It actually tells you the cancer types which they've actually found the mutation, and which cancer types and at what frequency. And I think somebody on the chat had mentioned, how do you kind of determine what is actionable, and how do we kind of think about a gene in terms of its kind of actionability, for want of a better word. So I've given here two examples of systems by which we can define that actionability. So on the left hand side is what's called the ESCAT scale, and so this has been designed by ESMO. So it's called the ESMO scale for clinical actionability of molecular targets. And so you can see here that you go from tier 1, which is what is really clinically relevant and where you've got reasonably high level of evidence, either in terms of randomized clinical trials, such as obviously HER2 in breast cancer, BRCA in breast and prostate cancer, or you've got clinical benefit in either in prospective single-arm trials or basket trials, such as ROS1 or BRAF V600E in non-small cell lung cancer, or NTRK fusion in non-small cell lung cancer. So that's your tier 1. You then have your kind of tier 2 and tier 3, which describes genes which are potentially clinically relevant and might have shown some benefit either in terms of retrospective trials. So these might be things like PIK3CA mutation in prostate cancer, or where you've got, for tier 3, clinical benefit in other tumor entities. So for example, PIK3CA mutation in non-small cell lung cancer. And then as you go down this scale, you can see here that you have lower level of evidence, which might be from preclinical studies only. Okay, so we sometimes use these. I mean, the utility of this, I know certain GLHs and GTABs use these frequently. We use it on an intermittent basis. On the right-hand side is the OncoKB, the Memorial Sloan Kettering therapeutic levels of evidence. And it's kind of a similar type of thing in terms of this kind of trying to understand this scale of actionability, and therefore giving a recommendation based on whether it's standard of care, investigation, or completely hypothetical. And I just wanted to highlight this particular project that we've been involved with, guys. So this is basically use of an AI-based NLP. So this is natural language processing to try and improve identification and efficiency of matching patients' genomic data to clinical trials. So we collaborated with this AI company called Inspirata. They have a tool called Trial Navigator, which in essence enables you to access key information from a clinical report, and that can include a genomic report. And with collaboration with the ECMC, we were able to link that Trial Navigator directly with the EC Trial Finder. We did a retrospective review of about 50 patients that had Foundation Medicine reports and tried to work out whether it was able to identify suitable trials. And we actually were able to identify at least one suitable trial for over 90% of patients, and we're actually able to identify genomically matched trials for over 70%. One of the key things was that we were actually able to identify a whole bunch of trials that we were not aware of, or that were outside our own center or geographical area. So potentially this, it just gives you a kind of flavor of how we might use AI in collaboration with clinical decision support tools, really to try and maximize the number of patients that we're able to put onto clinical trials. And finally, I just wanted to mention about the importance of germline evaluation from somatic testing. So we know from these big, large-scale studies such as MSK Impact, and also I've mentioned here big series from Michigan and MD Anderson, that when you're doing somatic gene testing, you actually are able to pick up unanticipated pathogenic germline variants of clinical importance in approximately 10% of patients. So that's really one of the key roles of the GTAB, to try and review these kind of pathogenic germline variants and then make sure that clinically appropriate decisions and support is given subsequently. So this is actually a case of ours from 100,000 Genomes project, which I just thought kind of highlights, precisely, the importance of this type of approach. So this was a 55-year-old lady with triple negative breast cancer who was actually initially referred to clinical genetics back in August 2016, but at the time she was ineligible for germline BRCA1/2 testing based on the NICE guidance. She had her standard treatment of a mastectomy and chemo followed by radiotherapy, and then she was enrolled in 100,000 Genomes project, and this just gives you a kind of snippet from the whole genome sequence report, which basically showed that she had a pathogenic BRCA2 variant. And she was then able to go on to the Olympia trial, which was targeted therapy with the PARP inhibitor olaparib. And clearly, this also has implications for her in terms of, prophylactic management of subsequent left-sided breast cancer and also ovarian cancer, and obviously implications of result for the family. So really, the 100,000 Genomes project really enabled the identification of this BRCA2 mutation, which otherwise wouldn't have been found, resulting in obviously hopefully the benefit for the patient and relatives. So just to conclude, NHS genomic medicine initiatives are really likely to have a increasing impact for cancer patients over the next few years. I think hopefully I've highlighted to you obviously that there remains significant practical challenges for how we translate that tumour sequencing into clinical decision making. Education of our workforce and really embedding genomics in diagnostic and treatment pathways is really going to be critical. And as I've tried to allude to, that linking of genomics to precision medicine carries a lot of promise, but it remains challenging. Things we need to think about around genomic profiling techniques, the matching criteria, how we select drugs, and reliability of access to those drugs. So with that, thank you so much for your kind attention, and I'm happy to take any questions.
That was fantastic. We have a few more questions in the chat already. And you've kindly answered one of them around actionability, so you're already ahead of the game. The next one, and I think it's probably because it's grabbed the headlines so much recently, is what's the difference between Guardant 360 and a test like Foundation One?
Okay, so yeah, Guardant 360 is a circulating DNA, which is similar to the Foundation One. Foundation Liquid CDX report that I showed. So there isn't really much to choose between them, in all honesty. And one of the things that Chrissie mentioned in her talk was this GMSA kind of pilot project that is going to start very, very shortly, where patients with newly diagnosed non-small cell lung cancer will have access to this ctDNA technology, either Foundation or Guardant, depending on the GLH that you're in, and really to look at the utility of that in that very, very early diagnostic setting for patients with advanced non-small cell lung cancer. So that's a pilot project that we hope will roll out to other tumour types. Both Foundation Liquid CDX and Guardant currently are not on the test directory, so these are not things that you can access currently on the test directory, but obviously dependent on the results of these types of pilot projects and other initiatives going forward. Hopefully at some point in the future, this type of technology will be widely available for all.
Some really exciting stuff coming through. And then I think we'll finish with a question from Alex, which is also a question that's on my mind. So there's plans for multi-omics in the next stages of the Genomic Medicine Service. They ask, is there a plan to introduce whole transcriptome analysis? What are the key considerations? How do we manage the availability of tissue and the lack of validated transcriptomic-based biomarkers?
Yeah, really good question. Look, I hope we're at, we will be at that point within a few years. I think clearly, you could, given the challenges that we already have in terms of doing what would be regarded as routine genomic testing, clearly we're not at that point yet, but that absolutely is the ambition for the future. And so, yeah, I think that, that use of integrated omic technology, be it transcriptomics, proteomics, all of these things, I think, will become, that is the future. But we're probably some way off that yet. Chrissie, I don't know what you're...
Yeah, I was just going to add to that. I mean, saying that within the Genomic Medicine Service, they're building the infrastructure to do it. And there's some pilot work, not in cancer, but on the rare disease side, which we're doing a pilot of in the Southwest. So it's about, the infrastructure is being built to deliver it. But I won't sort of repeat what Debs has said. It's going to be a little while yet, and we really need to get our regular work well and truly sorted and underway and running smoothly first.
And no doubt some of that includes the fresh frozen pathways,
exactly,
and not disintegrating all your RNA on the way.
Yeah.
And once, as we keep on saying, bit of a broken record, but it is all about equity of access. And if we haven't got equity of access at the moment, so we need to do everything that we can to make sure we have that equity of access. And once we've achieved that, then obviously all, everything else is kind of completely open and available to us. So yeah, I think, we absolutely hope and vision, but I think we're probably a little way off.
Actually, could I just add, it's not directly related to equity of access, but there's also a big piece of work in conjunction with GEL around diversity and creating diverse genomic data for us to use and utilize across different ethnic backgrounds. We know that our genomic makeup is different across different ethnicities, and most of the data we have available through 100,000 genomes in UK Biobank is white British. And so it's great to see there's a concerted effort around that, but we don't have that data yet. But as a nation, we're working towards that.
And actually, I know the Genomic Medicine Service have been really keen to encourage kind of grassroots projects in that. So I know a colleague of mine is actually doing some work in clinical genetics with transgender patients, which is hopefully going to be rolled out as well. So I've got wind of that. So that's really good, I think. I will just sneak in one further practical question from Jennifer, which I think is important. Which results are discussed at she's written TMB, but I think she means GTAB. Does the clinician get the result back and refer for discussion if unsure, or is it automatic?
So we don't discuss every patient in the GTAB. So basically, routine standard of care genomic testing and things like KRAS, the standard kind of KRAS variants, BRAF, EGFR, those kind of things we wouldn't normally discuss because it's normally pretty straightforward, and obviously the match therapy is available as standard of care. So the types of case that we discuss are variants where there are potential consideration around clinical trials. So for example, we've discussed a whole range of patients really in our GTABs with non-V600E BRAF for things like lung cancer and colorectal cancer, precisely because, we have things like that Roche Tapestry study coming up along where, these kind of class 2 or class 3 BRAFs can be potentially enrolled into, one of those arms. And then, so anything that's kind of standard of care, we wouldn't routinely discuss, just because obviously then we just wouldn't have the scope to be able to do that. But those other variants where there are potential other findings of significance that might lead to consideration of a clinical trial or compassionate use access, and for patients that have potential variants of germline significance, absolutely should be reviewed in the GTAB.
That's brilliant. Thank you very much. And so all that remains is me to thank both of our speakers for truly excellent talks, and there's lots of thanks coming in on the chat as well. To the attendees, please don't forget to complete your feedback forms in order to get your certificate. The webinar series will continue on the 19th of July with a session on skin cancers, which will cover both melanoma and non-melanoma skin cancers, and you can register at the acp.org.uk. Thank you very much, and good night, everyone.